Okay, so welcome to my lecture live from my kitchen here in Chester. My name is Connor-Scahill. I'm one of the senior lecturers in mental health at the University of Chester, based at Riverside campus, although I do, like many of the other lecturers, work across different campuses as well. So what I'm here to talk about today is working with families with psychosis. It's something that I have a lot of experience in clinically when working out in the community in specialist services, most particularly in early intervention in psychosis services. But it's also something that I bring into the classroom to talk about quite a lot with students. So obviously I'm aware that I'll be addressing today's lecture to many prospective students who are thinking of studying mental health nursing at the University of Chester, but also I'll be speaking to you mums and dads and carers of your loved ones who are thinking about coming to the University of Chester and to see whether it's a sort of place that would be worthwhile studying undergraduate or postgraduate mental health nursing. So let me tell you a little bit about myself. So obviously I'm a mental health nurse, qualified approximately 25 years ago, so I've got a reasonable amount of experience in the field of mental health nursing. But with regards to talking about families with psychosis, I have a particular passion because I have a brother with autism who's been in and out of mental health services, and that's sort of the expert by experience perspective is something that we bring into the classroom a lot. And it's something that I'm really passionate about, and I know many of you watching this video will have your own experiences either individually or from a familial family point of view around working with psychosis, dealing with mental health problems, whether they be mild or moderate. So let's talk a little bit about working clinically when you're a student at the University of Chester and working in the classroom. So with regards to working with people with mental illness and psychosis, we would use some of the academic approaches to how we work with families. And many of you may be sitting there thinking, that isn't something I could even imagine doing. Working with a family who've already had to deal with a diagnosis potentially of something like schizophrenia. And how would I go about working with a family to support them, to help them understand and come to terms with the diagnosis? To see it as less of a disabling diagnosis and more of an opportunity to be able to thrive. So what we do at the University of Chester is we try and bring real life experiences into the classroom. So for example, many of you would experience facilitated simulation sessions either in the classroom or in the simulation suite. So for example at Riverside we have a flat that we use to kind of create what it's like to really visit a family in the home. At my campus over in Warrington, we also have a simulation house, which sometimes we can collaborate with the police to try and simulate extremely real life experiences, whether it's dealing with people with severe depression, drug and alcohol misuse, and so on. But for the purpose of this session, in terms of working with families, one of the things we'll be looking at, well, two models I guess I bring into the classroom. One is, and maybe some of you want to take some notes, one of them is the Meridian Family Interventions Project, which is generally researched by Grania Fadden, and that's a very structured approach to working with families, which deals with three main areas. It deals with communication, it deals with problem solving, and it also looks at the concept of education, or psychoeducation as it's referred to in the academic literature. Now what we're talking about in those three areas, problems or problem solving is something that all families, I'm assuming your family, certainly my family here, the kids are all upstairs being very quiet for me, we have to work with problems. And sometimes families, your family's no different probably to mine, sometimes families don't talk about problems. Problems are something that's hidden away, thrown under the rug, so to speak. And what we try and encourage using family interventions is the idea of talking and being very open and transparent about problems and changing the dynamic within the family, changing the way that you work together as a family. So we may, for example, suggest the idea of how often do you as a family, not you listening to this lecture, but the fictional family that we're imagining working with, how do you work with people, talk to each other, and how often do you spend sitting down eating a meal? So it's not uncommon for most families, those with or without the experience of psychosis, to get out of the habit of sitting down as a family. And so a problem-solving approach using the Connor-Scahill approach to family interventions can start to just give families some quality time together sitting down eating a meal. That could be one example. Another may be, when was the last time you as a family went for a walk? So you may be thinking, well, how would you bring this into the classroom? Well, that's where yourselves and some of our other trained simulators come in, so we can create roles within the flat, within the simulation suite, within the classroom, that talk about create real situations where you will feel as the student, you will feel the stress of a real situation. So we create that, we simulate that environment, that learning environment for you. And within that we'll utilise various approaches, such as we will often use the timeout approach, which allows us to freeze frame the simulation, your learnt experience within the classroom, to think about and incorporate other people into the classroom who may not be as involved as you are, to think about how we would approach the particular scenario or particular clinical challenge you're faced with. I'll give you an example. The mother or father who are really angry with the young person with psychosis. Now, we would probably assume that being angry is not always a great emotion, but it's an understandable emotion. So what we try and relate to the family through various skillful approaches of reflection and support and relating to the family is a way of them understanding that maybe there's a better approach, or maybe there's a different approach, or maybe there's just an opportunity to try something a little bit different. Okay, so problem solving would be the first. The second approach would be communication. And communication is an interesting thing in terms of how families communicate. And once you have an opportunity working with a family to understand how they communicate, we may get an understanding of where some of the problems arise. We're not saying that families cause psychosis, but what we are saying, and from the literature, if you look at the change in mental health services from the early 1990s, they moved from an institutional, hospital-based, the asylum approach, into the community. And what we started noticing in the 1990s were that people who lived with families quite often relapsed quicker when they went home, as opposed to people who were discharged from hospital and went to live on their own in a flat seemed to be able to stay at home for longer. Now, that's an interesting question. Why is that? Is that because families at home overcare, over-support, and that people who live in isolation tend to be able to just deal with their symptoms of their illness if they relapse? It's an interesting question. I'm not going to pretend I have all of the answers, and I think that's something we'll often bring into the classroom, is that we don't have all the answers, but we'll refer back to you as the student to try and hypothesize, to try and understand why that may be. What we do know is that people working in families, living in families, tended to end up relapsing sooner. One definite explanation for that would be people feeling ostracised, a little bit isolated in their family, feeling like their family relationships were not quite as functional or as helpful as they would be if I were 19 or 20 years of age. Imagine if I lived on my own. Most 19 and 20 and 21 year olds like the idea of living on their own and feel a little bit got at when they live at home. I'm not trying to target that or any of you potential students, but we know we were all 19 at some point in our life, and we know that life can be challenging when we live in one space, one shared space with our family. And the final aspect of the three Connor-Scahill approaches to family interventions would be around education. And we call it a little bit pretentiously in the academic literature psychoeducation, but it is psychological education around what we mean by psychosis. And I think it's really important for families. They'll often have 1,000,001 questions when we visit them, and that'll be part of the initial screening process, where we'll say to families, ask us questions around anything you want with regard to your son and daughter's diagnosis, the medication that they're using, the symptoms that they present with, their motivational levels, which are either higher or lower. All of these are symptoms, positive and negative symptoms of mental illness. Okay, so that's one model. The other model is a Christine Barraclough model from Manchester, and I'll suggest and ask that some of you who are interested in working and studying in mental health nursing go away and look at the different models. One is quite a rigid model, has quite a rigid approach to the sort of steps that I described. The other one has more of a cognitive behavioural approach, or CBT, cognitive behavioural therapy approach to family interventions, and that has a lot more relationship with the way we think, the way we feel, and the way we behave. But we haven't got time in a 15-minute lecture from my kitchen to go into that much detail, but I thought it would be important just to give you a little bit of an outline around some of the information that we would hope to bring into the classroom. Now, I know we're going to have an opportunity for you to ask questions, and I will be answering and responding to some of those questions as well. That may well be about the experience of being a mental health student at University of Chester. It may be about how often I go out into practice as opposed to how often I study in the classroom. And I think some of these bits of information will probably have been made available to you. But for example, if you go out to clinical practice, does that relate to some of the things you learn in the classroom? Well, of course it does. It relates to the experiences you have in the classroom, often because the information, the scenarios, the challenges that you bring to people like me in the simulation suite, in the classroom, from an educational perspective, are things that you bring from your own clinical practice. So you will have been out in clinical practice for 6 to 8 to 12 weeks, depending on where you are in the programme, and you will then come back into the classroom for blocks of 3, 4, 5, 6 weeks, where we'll look at particular aspects of your education. They could be skill focused, they could be knowledge focused, or they could be a combination of the two. So you'll be able to bring a lot of these things from clinical practice into the classroom with myself and many of my colleagues. And you won't just learn from a family point of view, you won't just learn from the psychiatric, psychological point of view, you'll learn more of the skills from a more physiological, general medicine, general health perspective as well, so that when you visit families, so that when you're a student working with our other experts and clinical specialists out here in Cheshire and Merseyside, that you have a really broad knowledge and understanding of the broader sense of health. And it's not just about dealing with more of an old-fashioned approach to, we deal with the psychosis and we don't really do anything else. Because the difference between the sort of family interventions working with psychosis that I'm talking about today and how we used to do things even as recently as 10, 20, 30 years ago, is that we now visit people in their homes. We don't expect them just to come into the clinical environment to see us in an outpatient clinic, although that still happens. But we have a variety of places where we can work with families. Another interesting development with family interventions, and it actually took some sort of prevalence, if you like, in America about 20 years ago, was this notion of multiple family sessions. So you bring families together. Now, it's not something I've got a massive amount of experience in, and the literature is a little bit kind of variable, because if you imagine this, if you've had a disabling diagnosis and an illness such as psychosis or severe depression, and what we do is then bring you in from one family and another family together to have a multiple family session, whilst there's so many opportunities there for mums and dads and sisters and brothers and the clients, the service users, the people themselves to mingle, to integrate, there's also the opportunity for them to clash. And that can happen. So working with multiple families is one approach. What I prefer to do in my experiences working with early intervention and psychosis services is to bring service users together. Now that creates a different concept, a different notion of family. So who do you identify with as your family? Yeah, it's often your mum and dad, or your carers, or your sisters, or your brothers, but it's often as you get older, and certainly go through your adolescence and beyond, it's the people around you who are important. So it's friends, it's people who you work with. It's not always family. So this notion, this concept of family widens. And hopefully that's something that we start to talk about in the classroom when we think about family interventions, working with people who are suffering from mental illness. I used to work, for example, in homelessness. And when we're talking about family interventions there, we're talking about systemic families. So we have to talk about the family around the person, which will often be hostel workers, drug and alcohol detox workers, their mental health nurse, possibly a long distance relative who they haven't seen for 5, 10 or 15 years, but that's something who they want to see. So I'm going to stop talking now because I think my 15 minutes are about to be up, and then I'm going to be able to answer some questions to some of you if any of you engage in the chat. So thank you for listening. I hope it's been a little small snapshot into what it might be to work within and study within the University of Chester. I would probably be some or not, if not many of your personal academic tutors based over at Riverside in Chester, but all of my other colleagues within the mental health team and learning disability team are fantastic. So we'd welcome you and we'd look forward to working with you as well. So good luck and enjoy the rest of your summer in 2020. Challenging, but I know you can do it. All right, thank you.